be unstoppable. The beating of the drums earlier was signifying the birth of that movement. And this woman is going to push this baby out. We call you to join us as we push for this birthing of this movement. Let me encourage you, there will be so many tools, networking opportunities, because for this movement, you need a lot of fueling. So within the next 3-4 days, we will be by the filling station, getting our tanks filled, ready to roll. With those few remarks, honorable people, our excellencies, let's welcome to the stage our wonderful, amazing Director General, who has welcomed us so very well, Dr. Sandile Buthelezi, to the stage. Thank you.
Thank you very much, Program Director, esteemed Ministers of Health present from Equatorial Guinea and Liberia, conference co-chairs, Dr. Dube and Dr. Ansu Banerjee, esteemed delegates present here today, our different partners from different UN agencies and all the other multilateral and bilateral agencies. Let me start by conveying warm greetings on behalf of our Minister of Health, Dr. Joe Pahla, who you will see this afternoon. He will be joining us just after lunch, just to address us here. I warmly welcome you to the second biennial International Maternal Newborn Health Conference in Cape Town, and into our beautiful country, South Africa. Thank you to our co-hosts, AlignMNH Secretariat, for hosting this important conversation with us. As you know, this is the first time in the maternal newborn health community is coming together in 8 years. It's hard to imagine the world 8 years ago. We had just hit the deadline in the Millennium Development Goals, and we realized that we were off track and needed new targets. Many of you gathered in Mexico City in 2015 to discuss maternal newborn health and drive energy and attention for progress. At that point, we had no idea that we are about to be hit by the largest epidemic ever experienced in terms of COVID. What we will be discussing here for the next 3 days is very important for the country. And Ansu, I was just looking at your portfolio within the WHO. It's a very long portfolio, but I will summarize it that from birth to the grave. We really appreciate that you've been part of this. There are many dimensions that we need to deal with when it comes to quality, because quality is what is mainly a problem. Here in South Africa, when we look at the topic that we have here today, we look at the 5 critical problems, and we summarize it as the 5 H's that are a problem in terms of maternal and neonatal death, but mainly also focusing on the maternal health and maternal deaths. The first H being the hemorrhage, the second H being the hypertension. The third H, I think we are making huge strides, which is HIV. The fourth H is the health sector platform itself and social determinants. And the last H being the skills of the healthcare worker that we really need to be looking at if we really need to have very good outcomes when we deal with issues that we will be dealing with here today. So for us, it's really to see that how do we improve the quality of services. And when we actually look at the issues, we need to look at coverage, quality improvement, and actually ensuring that we've got the right skills, the right products, the right processes in the right place at the right time. So for us, we need to ensure that our services are user-centered. It's not about health workers, but it's actually about maternal experience and the maternal well-being, so that we have the good outcomes, and the neonate is just the comes out quite clear and we don't have problems. So as we gather here today, can we please use this opportunity, not just as a talk shop, but just to ensure that our mothers, our children, we have good outcomes and we are able to reach our SDG goals. So as we meet all of us, please use this opportunity. Let's learn from different countries. Each and every country has got best experiences that we can actually pull together and actually bring them to practice in our different countries so that we are able to achieve what we need to achieve. On that note, welcome to South Africa, and we wish you the best for the next 3 days. Thank you very much.
Individually, we are one drop. Together, we are an ocean. Welcome to the International Maternal Newborn Health Conference 2023. The first time we've all gathered in 8 years. Take a moment to look around at one another. We are colleagues, we are peers, and we are friends. And together, we share the spirit and soul of the maternal newborn health community. This week, we'll be aligning together to ensure we meet the ambitious but achievable 2030 Sustainable Development Goals. Accelerating together to advance solutions to improve maternal and newborn survival and to prevent stillbirths. And bringing forward new evidence, sharing ideas, and driving efforts to save lives. Together. Thank you for being here. As a community, we have the insight, experience, and motivation required to overcome the challenges we face. And we have the spirit that it takes to drive change. As we know, progress in maternal newborn health and stillborn reduction has been made, but it has been inconsistent, too slow, and often does not account for the combined needs of the mother and newborn. In 2000, neonatal mortality accounted for 41% of under 5 deaths globally, but it is not reducing at the same speed as under 5 mortality. And in 2021, it accounted for 47% of under 5 deaths. From 2000 to 2015, the maternal mortality ratio declined by 33%, but since 2015, it has barely declined at all. A baby is stillborn once every 16 seconds. If current trends persist, 60 countries will not meet the SDG target for maternal and newborn mortality and stillborn reduction by 2030. By coming together this week, we are uniting in thought, dedication, and action to shift these trends. Together, we have made progress. We know that maternal and neonatal death and stillbirth often have common causes, and we can prevent them. A number of countries have achieved significant and measurable progress in maternal newborn health. So we know change is possible, and we can learn from these countries here at AlignMNH 2023. We also know there are challenges. Limited financial resources need to be addressed to ensure that integrated quality care for mothers and newborns is part of a core package of funded services in every country. Poor quality of care and care silos generate harmful competition for attention and resources and fail mothers and babies. Important differences among regions and countries must be recognized, and communities need to be engaged in care. Innovations are also needed to expand access to services, fill gaps in existing services, and reduce inequity for women and children everywhere. As part of this, we must build strong routine data systems in order to measure progress so that we know if we are on track and to hold ourselves accountable. Together, we can achieve 90-90-80-80. That's 90% coverage of 4 or more antenatal care contacts, 90% of births attended by skilled birth attendants, 80% early routine postnatal care within 2 days, and 80% of districts with at least 70% ANC4, 80% SBA, and 60% PNC coverage. Now is the time to unite in action. Because if we don't all make the SDG targets, then none of us do. Collectively, with our knowledge, our experience, and our spirit, we can ensure that all mothers and newborns not only survive, but thrive. Together, we are AlignMNH 2023. It's not a moment, it's a movement.
Joining us via video, the Director General of the World Health Organization, Dr. Tedros Adhanom Ghebreyesus.
Excellencies, dear colleagues and friends, I thank the government of South Africa for co-hosting this important conference. It provides a forum for accountability as we reconvene every 2 years to measure progress, assess challenges, and learn from one another. While we have made much progress on reducing maternal and newborn mortality in the past 20 years, reductions in maternal deaths have now plateaued, and newborn mortality still accounts for almost half of under 5 mortality. Every year, 4.5 million mothers, newborns, and stillborns die from preventable cause. Where a child is born or how much money its family has should not determine whether it lives or dies. But this is still the reality for many women and babies worldwide. Over 60 countries are off track to meet the maternal, newborn, and stillborn mortality reduction targets by 2030. We need urgent action to reignite progress, which could save 7.8 million lives. We call on all countries to develop and finance evidence-based plans for maternal and newborn health, and to integrate programs for maternal newborn health into universal health coverage packages delivered through primary health care. Thank you all for your continued commitment to a healthier, safer, fairer future for all mothers and newborns. Together, we can make it a reality. I thank you.
I would like to introduce you to my new friend, Treasure Luwantali.
Yes.
Treasure, welcome to the stage. Please take a seat.
Thank you.
All right. Just an intimate conversation. Don't mind 1,500 people out there.
Exactly.
And the millions watching virtually. Whew. That's what you're thinking. I'm sure you're thinking that. I'm going to take you back to January 2021.
Right.
Okay. This conversation is, I know your story. For our audience out there, do you mind looking that way? They're going to be very supportive.
Thank you.
38 weeks pregnant, January 2021, and something was not quite, you had a feeling. What was that feeling?
So, I was 38 weeks pregnant, and I just felt like my baby was not moving with enough strength, his usual strength. And so I expressed my concern to my husband, who together we just prayed for the baby. And we just decided that we'd go have a check just so I could settle my feelings. But that was for the next day, because we didn't know that it was a matter of urgency. We didn't have any information in that regard. 9 months, many appointments, but no information concerning the fact that you should take that really seriously. And so we went the next day to the hospital, and we were received, and first person I spoke to said, how many children have you had? The receptionist at the hospital. And I said, this is my first. So she said, oh, okay, just have a seat right there. I could tell from her countenance that the fact that we walked in with my husband, being Mary and, caring about her child, my pregnancy, she sort of like thought it was maybe just us being lovey-dovey. And so we just sat there, and 4 hours later is when the doctor comes, and he was changing shifts, so they get into a conversation, and I was invited in as they give me to the next doctor, and then they begin to talk. So they ask, so what's the problem? I say, I don't feel he's not moving as strong as I'm used to. And he says, okay, how many children have you had? So I say, it's my first. And say, okay, just wait. And so they speak and speak and speak. And then he changes coats and then comes over to me and said, what's the problem again? So I said the same. And then he says, okay, so lie down, let's see. So when he checks, he then opens his eyes wide. And then he asks for a Doppler machine. And then he checks again and says, oh, this is an emergency. You need to get a scan right away. And he calls in the hospital. The scan people were not around. So he tells me, go to the nearest place you can get a scan and bring me back the results. So my husband and I walk out and find the hospital, and we go there all this time not aware of what this outcome looks like, but anxious, even more anxious now. Earlier on in the waiting, we had tried to download apps on the phone to help us check for a heartbeat because we were waiting and not knowing. But the apps, obviously, we'd put them on the wall and they'd see a heartbeat on a chair and they'd feel a heartbeat. So we were confused, but nonetheless we needed to wait for a medical practitioner, so we did. Anyway, so now up until this point we go into the scan room and they scan, and the lady, she looks at me still, eyes wide open, and says, I think we've lost the baby. I can't see a heartbeat. And so I asked, what does that mean? Like, what happened? Like, what's going on? And she says, well, I'm so sorry, but I think you've lost the baby. Take these results immediately back to your doctor. From there, we went back there, and then that's when everybody started rushing a little bit, that, this is what's going to happen. We have to get the baby out immediately because, it's dangerous for them to stay within you. And so, then we went on to that process. I was induced, and
Can I ask you, between when you went to the hospital and you had a feeling as a mum something was not right with your baby, to the point where the health care team believed you, how long was that time period?
I think about 4 hours and 40 minutes. Yeah, because I know for sure we waited for 4 hours, about 4 hours and 10 minutes, because my husband was counting. I was getting agitated. He was trying to keep me calm. So he just kept on saying, okay, something is really wrong. We are here. We are in an emergency section. It was a Sunday, so as hospital protocol, on Sunday, they receive us in the emergency because they don't have a lot of staff on work. So we were already in the emergency section, but things were not being emergency for me. People were coming in, and then the receptionist, who earlier asked, is this your first child, or, who kept on putting them first, and we sat there,
If you had to describe the way you were treated at that point, what word, what sentence would you use?
I don't have the words. I really don't. I just think it was really unfair to my baby. Yeah, really, really unfair to my baby. I mean, I know even other people who came and needed care, emergency care, they needed it, but so did I. Because a baby is inside, I'm the voice, I'm the mom. I'm the one who knows what is wrong. And when something is wrong with him, I might not look like something is wrong. I will not look like something is wrong, but I'm the one with the baby. From that experience, I knew that a mother knows. Yeah, and they're the only voice until the baby comes into the world. So I wish they would listen. I just wish they would listen. I'm sorry.
You don't have to apologize at all. So, your baby is a little boy, Mwesi.
Yeah, that's right.
It's a beautiful name.
Thank you.
So, Mwesi died inside of you. So, he was stillborn.
Right.
Treasure, I'm so sorry to ask you this, but how long was it before you were able to actually see Mwesi? Because you knew he'd passed away, but that time period, how long did that take?
Oh, it took 3 days.
All right.
3 days. 3 days, but I'm glad I got to see him. Yeah.
You're not seeing what I'm seeing, but I know you've spoken and you've told your story before. When you said 3 days, it was just appalled. People were appalled. 3 days.
Yeah, 3 days. I was in labor for 3 days. They gave me slow inducers, then fast inducers, and then because it was COVID time, almost at the peak of it, so there were no private rooms, no separation, because the rooms were being used for, daily high-profile people who would get COVID. The hospital had good rooms for maternal, and they sort of served them better for COVID purposes. So they put us all in like a combined room, which is normal for like hospital. That wouldn't have been a problem, but then especially given the circumstances. But all throughout the 3 days, there's moms coming in and giving birth and going, and you're in labor and everybody's whispering because the nurses have said you lost the baby. Everybody knows you lost the baby. As the moms walk and they're in pain and they're telling them, don't worry, you're going to see your baby. They don't know what to tell you. Yeah, like hanging there, they don't know what to tell you. So
there was one nurse
right
in this whole horrific experience that made you smile.
Right.
Like you're smiling right now. You're
Yes.
even thinking about this nurse, you're smiling.
Yes.
What did she do and how did she do it?
So she was a midwife, and she came in the second day, and she found out what was wrong. She actually asked me, had you picked a name for your baby? I said yes. He was called Mwesi. And so from there on, she referred to him by his name. And she said, I really want to deliver Mwesi. I'm here for you, and things like that. So that day when I was due to give birth, she told me, my shift is done, but I'll stick around to make sure I deliver Mwesi. And she did that. And when I gave birth to him, she asked if I would like to see him and if I had prepared clothes. Of course I had. It was 9 months. I was looking at them, folding them, packing them, and unpacking them for like 5 months before that. So I told my husband to pick them, and she was rushing. It was like she was going to give me an alive baby. And so she dressed him up and tucked him in and put him in the receiver that I wanted. And she brought him, and I looked at him. I carried him. My husband and I had some time to look, to pray for the miracle, which we realized it wasn't for us at that time. And then we saw him. He looked like me. And And so we looked at him, his face, his hands. We carried him. I had a moment to be his mom. Yeah, and so she said she'd be around. She said if we wanted anything. So I asked for pictures. At this point, I don't even know why I'm crying now. I was smiling. I was so happy to meet him. And so I was smiling. I didn't even know. Anyhow. So she asked us to take pictures. She took pictures of me and him and my husband and him. And then she said, when you're ready, you can call me in and I'll take Mercy. And so when we were ready, we called her and she took him. And I was wheeled out of the labor suit, which is where all this happened. And at that point, I just couldn't find the sadness I was carrying for the 4 days leading to that day. And so they wheeled me back into the ward. I was smiling. The people in there, they expected that I'd probably be bawling my eyes out. So, but when I walked in smiling, some of them did clap. And I was shocked I was smiling. My mom, she was shocked. And so she looked for the midwife quickly and had a few words of thank you. And yeah, so she gave me a memory with my son, a good memory. Yeah, with my son and with my other children. Oh, thank you. I'd like to say this if I can. Yeah, of course. Yeah, thank you. So the thing about a stillborn child, and in my experience working with moms also who have experienced this, is that as a mom, 9 months leading to when you give birth, you are looking forward to being your child's mother. With a stillbirth, you only get the moment at birth to do that. While the rest, you think about graduation, you think about all these things. For them, that's it. And motherhood is a gift. So the best gift that midwife gave me was to mother Mwezi for that moment. It's all I had, it's all I'll ever get in life. Yeah.
Treasure, just your story by itself teaches us so many lessons. And thank you for sharing your story, and you continue to share your story. Because hopefully other families, parents will have a better experience than you had.
Yes, that's why I'm here, and that's why I'll keep doing this. Yeah.
We appreciate you. Thank you.
Thank you.
I can't think of a better person to follow Treasure than Rachel Toku Apaya. She's from the Bill and Melinda Gates Foundation, part of our opening ceremony. And Rachel, this is a very difficult part of the program for you to come and join us. But I'm going to ask you, and I know that you're more than capable of working out what do you say after Treasure has told her experience of what happened to her little boy Mwesi. Rachel Toku Apaya, are you ready?
Good morning. All protocol observed. As you just observed, I came to the podium a few minutes late. Sometimes things don't go as we planned, as we hoped for. The story that Treasure just shared with us has left many of us reeling, hurting, angry. It's hit somewhere deep within us. But we have an opportunity to take those emotions and turn that into something positive, to allow Treasure's experience, and that sadly of far too many women and families, to instill in us a steely resolve to do even more and to do it faster. We heard earlier how the progress that we've been seeing over the years has plateaued. This community coming together can change that. And I'm honored to be here, to be a part of this historic gathering. At the foundation, our vision of a more resilient and equitable world starts with healthy mothers delivering healthy babies. One of the most important ways to support women is by investing in their health, in the tools, services, and counseling that they need to live healthy, productive lives. And over the next few days, there will be many sessions where we have an opportunity to learn more about the new technologies that are evolving. We heard, for example, how Treasure couldn't get an ultrasound scan straight away. We know that we now have handheld scanners, for example, which, if we're able to scale up, can make such a service so much more accessible. And too often, where you live and the quality of care you receive determines whether life will begin or end during childbirth. Many proving life-saving interventions, like the one I mentioned earlier, do not reach the mothers and babies who need them most. We have made gains in maternal and newborn health, but this progress is slow, it's inconsistent, and it's not for everyone. The vast majority of newborn deaths occur in low and middle-income countries and communities. In 2020, about 70% of all maternal deaths were in sub-Saharan Africa. Let that sink for a moment. 70% of all maternal deaths across the globe were in sub-Saharan Africa. While we have seen great progress in reducing child deaths under age 5, the declines in maternal and neonatal mortality are declining at a much slower rate. Stronger accountability, from policy design to funding to program implementation, is critical to improving maternal and newborn health outcomes. We aim to accelerate progress toward the SDG targets by better aligning the care of mothers and babies and supporting the development, testing, and scale-up of innovative solutions. We know that progress is possible. The launch of the Together for Change Progress Report later today is a key milestone towards aligning the maternal and newborn health communities, and by extension, policy and decision makers on shared targets to help lay the groundwork for further progress. As we come together here today at AlignMNH 2023, we will convene every 2 years hereafter to mark important milestones over the next 8 years as we progress to 2030. These convenings will allow us to collaborate and revisit effective mechanisms and approaches on integrated care, improved quality of care, and equity. These 2-year checkpoints will help ensure we're making continuous progress and keeping our attention towards 2030 goals. It will take all of us working here together to make it happen. There are many challenges ahead, but the energy and the excitement in this room makes me hopeful for the future. As we're gathered here, I want us to imagine ourselves in a relay race. We're in the home stretch. We've come a long way through the MDGs and now the first half of the SDGs. And as we look toward the finish line in 2030, we need to find the strength to put in that extra kick, that focus, which will propel us forward and over the finish line. And I believe, to borrow the saying of one of our famous presidents, together, this community gathered here, together we can. Thank you.
Our opening ceremony continues with USAID's Dr. Atul Gawande. Welcome.
Thank you to all of you for being here. Thank you to the Bill and Melinda Gates Foundation for the tremendous support that has made this possible. Thank you to the South African government for co-hosting us. Thank you to everybody in AlignMNH Secretariat and committees that made it all possible. But thank you also to Treasure, because we need to understand the experience one by one. And she brings home a key lesson about the challenges we're up against. When the last meeting happened, the wind was at our backs. The Millennium Development Goals were coming to their targets, and we had had remarkable progress. 3% annual reductions in maternal mortality rates, steady improvements in newborn survival. Treasure's story tells us about the places where we've plateaued, the places where we've even fallen back. Even before the pandemic, progress was slowing, but the pandemic has had a devastating impact. It disrupted and diverted resources from essential services, those same services that Treasure was relying on when she came to that emergency room, and it wasn't there for her. When her own room, where she could be cared for, was taken away. When the people who can be there and attentive had to be pulled to the lives of so many others who are being lost. Last week, the World Health Organization's Pulse Survey came out. It has happened 4 times during the pandemic, looking at what happened to our health services. And it described some signs of improvement, but ongoing disruption of essential services, including critical services for maternal care and for newborns. 84% of countries reported continued service disruptions in key child and maternal services. We've come through the pandemic with 67 million children who have not been vaccinated completely. we've lost years of progress. And the ongoing economic damage has been slashing our healthcare budgets, especially for health workers. What she experienced was a gap of support. What we see globally is a gap that was 18 million health workers before the pandemic, and now it's a shortage of 26 million health workers, because health workers' salaries have been cut, the positions have disappeared, or they've been pushed out by the pandemic itself. We have experienced the first global reduction in life expectancy since World War II. A story of decades of progress has been put into reverse. Last week, after 3 years, the WHO, Dr. Tedros, called an end to the emergency. Can we have a round of applause and celebration for that? We have the end of the emergency, but it is only the start of recovery. It is only the start. At USAID, we have recognized that our strategy for preventing child and maternal deaths has to change because of what we've experienced in the pandemic. We've had a primary focus on access to goods and services across our global strategy to keep driving towards the SDGs. But now we understand that this has to include a focus on quality of services in the face of disruptions and devastating setbacks, and on recovering equity. Because the places that are sacrificed first are ones that needed help most, and that is not the way it should be. Treasure's case brings home, her story brings home the challenge. In our global work that we've been doing at USAID, we have helped more than 44 million women, more women, give birth in health facilities, almost a 60% increase. We've expanded access to skilled care for 33 million newborn babies, trained 14 million health workers in skills for pregnant women and young children. But if the team can't come together to be there for people, if those workers are so overwhelmed that they can't provide the simple information that would have helped Treasure understand what the danger signs are that she needs to come in for, who is supposed to be there for the help, have been able to be known in the system by somebody who understands this woman does not complain easily. She's not someone who is lightly coming in to that emergency facility. She is someone who needs to be taken very seriously. Without that focus on quality, we are lost. To save lives, we must strengthen the quality of care, not just by investing in individuals and in their skills and in commodities, but by also investing in the teams who deliver care and the systems in which they deliver it. We've updated our strategy, and believe we all have to update our strategy to recognize where we are and that need for focus. We've come out of the pandemic taking very seriously, as we should, the need for pandemic preparedness. But we have not reignited that demand that it is time we recover. We talk about the SDG 2030 goals. We continue to talk about the SDG 2030 goals, and yet we've gone backwards. It is time to recover our pre-pandemic levels of survival and better by 2025. We have not even begun to get immunization rates back to where they were. We have the entire spectrum to work on. A critical element of this strategy for us is a focus on an initiative we've called Primary Impact, in which we are joining with WHO, the World Bank's Global Finance Facility for Women, Newborn, and Adolescents, and others in driving a radical reorientation of health systems toward primary health care. And we're starting with 7 primary impact focus countries that have chosen to join in this prioritization of primary health workers and their needs for successful delivery of care. Those countries are Cote d'Ivoire, Ghana, Indonesia, Kenya, Malawi, Nigeria, and the Philippines. What they all recognize is that the evidence is overwhelming that equity in reducing preventable deaths requires a scaffolding of strong community-based primary health care teams. When communities have paid and well-trained healthcare workers providing outreach and health services to every household, and when those workers are integrated into primary health clinics equipped to address the majority of people's health needs, survival rates rise dramatically. But too often, those primary health workers are the last to receive investments and the first to get cut when budgets are tight. Earlier this year, I was in Indonesia on a visit to Kupang district on the island of Timor, and I met Adriana Betty, a midwife who is the head of the Puskesmas, the primary health center for 9 villages with a population of 20,000 people. Indonesia has had a far higher maternal mortality rate than countries of its income should have, and the island of Timor has a far higher maternal mortality rate than within Indonesia. Indonesia, despite having resources, has focused its health investments on hospitals and secondary care. The Minister of Health said that just 10% of the health budget was going to primary care when he took office. But under his leadership, they'd increased the percentage going to primary health care to 25%, and he had committed to raising that level to 50% by 2025 with the support of domestic investments, the World Bank and the Global Finance Facility. And our USAID team had therefore worked to ensure that those investments could produce quality. And in Adriana Betty's primary health center, I could see the difference. She'd been able to ensure that critical supplies were in stock, that faulty equipment had been upgraded, and make sure their staff were enough that they could ensure an extra set of hands were always available to support deliveries and make sure no one fell through the cracks for their prenatal care and postnatal care. And then our USAID team worked to help her harness those investments and previous ones that had been made to steadily improve their quality of care. The leadership and staff, for instance, adopted the WHO Safe Childbirth Checklist and used it to strengthen and practice their work as a team. They were able to even reach the point that they were offering family planning advice immediately after birth, so that family planning and contraception offers could be made. They were giving instructions for the life-saving signs of danger, both before birth and after birth. And the result is, in their community for the last 9 years, they have not had a single maternal death. Not a single one. I'm going to do that American thing and knock on wood because I don't want to jinx them. You heard what we said earlier. This is not just a moment. This is a movement. And it is vital that we reinvigorate this movement. This conference is an opportunity to do just that, to identify our successes and what the evidence is showing us, to facilitate collaboration and learning, to address where we are not succeeding, and to prioritize the actions that support and enable these frontline workers to recover our lost ground and reclaim progress toward our SDG goals. Thank you all for joining in this vital work. Thank you for supporting the message that Treasure is bringing us. Now I'd like to introduce our next speaker to follow me, and that is Sibabatso Sawane. She's a registered nurse and midwife from here in South Africa. She's the founder of Black Women Arise Women's Health Foundation, increasing health education for women in need and increasing demand for quality services. In 2020, she was chosen by the International Conference of Midwives Young Midwifery Leadership Program. In 2021, the Mail and Guardian chose her as one of the top 50 powerful women in South Africa. She has worked in both private and public facilities and continues to work as a midwife part-time while taking on her ever-growing leadership roles. Please welcome Sibabatso Sawane.
My name is Sibabatso Sawane. I am a nurse midwife by profession, and I'm also the founder and CEO of Black Women Arise Women's Health Foundation and Black Women Arise Women's Health Clinic, a movement that I started with the aim to improve quality sexual reproductive health rights and maternal health services for women in impoverished communities, as well as to bridge the gap between women in the community and healthcare professionals, particularly midwives. As a young woman who could not afford private health care, I struggled with severely painful periods and went from pillar to post before I could be diagnosed and treated for endometriosis. As a midwife, I have practiced in a private hospital, which was a safe and well-equipped facility which empowered me to provide a positive birth experience for the women that I was serving. I have also worked in a hugely burdened public hospital which had little to no resources, where my passion had to stand in the gap as I found myself having to improvise to ensure that the women and children that I cared for got the care that they needed. I have received flowers from women who I had assisted to give birth as a token of appreciation for giving them their dream birth in their dream private hospital. On the other hand, I have also faced the disappointment and rage of impoverished community members as they wanted better services for their loved ones, while knowing very well that it was not within my control as a nurse midwife, and therefore receiving the rage on behalf of public governance. Even when these services were as basic as a decent bed and curtains to preserve the dignity of women. Furthermore, as a young woman who was born into poverty and only managed to escape its claws through education, which not all my community members had access to, including my own mother, I have made it my life's mission to advocate for women who are not as privileged as I am. Through the investment and mentorship of the International Confederation of Midwives and Johnson & Johnson through the Young Midwifery Leadership Program, I have been able to advocate and impact women in underprivileged communities because I know their pain. I know their struggles. When they die and their children die, a piece of me dies because I am one of them. And I am here to say that they deserve better. They deserve competent and passionate midwives to be with them through birth. They deserve decent and well-equipped birthing facilities. They deserve access to basic human rights, such as access to clean water and clean birthing facilities during birth. They deserve access to life-saving emergency obstetric procedures, and they deserve their right to informed consent to be respected. More than anything, they deserve to have respectful maternity care rendered to them irrespective of their socioeconomic standing. It is time to mobilize resources and to appeal to the conscience of the custodian of public funds and to bridge the gap. Let us empower midwives to practice safely and competently so that they can provide better care to women and their children. Let us invest in supporting midwives, which is a direct investment into the protection and health of women. Let us invest in our nations, because women truly are the backbones of our societies. And if you heal a woman, you heal a community. And if you heal a community, you heal a nation. I thank you.
How is everybody? Okay. Getting better. Who said getting better? Excellent. Thank you. Spontaneous Q&A. I was not expecting that. How wonderful. I love Q&A. All right. So, we are going to transition from the opening ceremony plenary to plenary 2, and you don't have to do anything. Just sit in your seats, and we will bring plenary 2 to you, starting with movement makers. Take a look.
Maternal mortality is one of the saddest forms of injustice that must be dealt with head-on.
Our focus on sexual reproductive health and rights and breaking the barriers that exist within quality healthcare service delivery is fundamental, so then women are able to access quality healthcare services without having to suffer from any kind of constraint.
Achieving quality maternal and newborn health is really about putting women particularly at the center of the conversation and recognizing her as a holistic approach in her whole life and not just that one event.
We see an immediate improvement in quality of care when small changes are made that contribute to an enabling environment for midwives and other healthcare workers.
Effective clinical and non-clinical interventions with a positive and supportive attitude from all our healthcare providers will provide a better birthing experience to all our patients, our newborns and their families too.
The mother-newborn dyad is a unique and inseparable entity that deserves integrated and respectful care throughout pregnancy, birth, and the postpartum.
Improving health data is crucial. Without valid and reliable data, it is hard to identify the magnitude of the problem and the root cause of maternal and newborn death.
The scaling up of affordable technologies ensures that newborns not only survive, but can thrive wherever in the world they are born.
Every mother deserves a chance to hold her healthy baby, no matter where they live, particularly in humanitarian crisis and conflict settings.
Let us celebrate our unique pregnancy journeys and take note that we must develop policies that intentionally include maternal mental health and newborn health as a priority in primary health care systems.
Our innovative maternal newborn healthcare solutions must foster environments where there is continuous conversation about improvement, change, and collaboration.
Our multi-sectoral approaches to maternal and newborn healthcare programs must prioritize youth engagement.
And advocacy is a must to ensure countries and communities have a strong policy framework and a health system that is well financed in an equitable manner so that we can end preventable deaths of mothers and children.
There is nothing that can beat peer learning because we always learn from each other and we can use that experience to promote newborn and maternal care.
The time to act proactively is now for the sake of future generations.
It is now the moment, it is a movement.
It's not a moment, it's a movement.
It's not a moment, it's a movement.
I am going to give you a very quick breakdown of the next 3 days. Day 1, today, what is possible? Day 2, challenges. Day 3, the future. So our plenaries, our discussions right now will be what is possible, the positive part of our journey, our working together. In the moment, we will begin our session, which is about the exemplars of success in reducing maternal and newborn deaths and stillbirths as well. That is what we're going to be focusing on. Which countries, which regions, which parts of the globe, how are they doing? How have they been doing? Where are the greatest changes happening? And what are the tools and the policies, the strategies to